I'm very intimidated because that's my style. My name's Phoebe Cushman. I work at Spectrum Health Systems, and I also work for Mixed App. So my question, I guess, is it's general. It would also be, I think, related for D. And that is one of the things. So I work at Spectrum Health Systems. I at an OTP in Framingham. And one of my questions is frustration that I often feel when I feel that I am on the verge of having to turn people away because they present with low CAL scores. They inevitably are people who like literally use fentanyl like a couple of days, a couple of hours before they present. And what is the best? I try not to turn people away. I end up kind of but what are your advice? What's your advice in that setting? I guess this is mostly an outpatient. This is an outpatient.
Sure, we should poll the room. I mean, I think I'm very grateful that I rarely see people with high CAL scores anymore, because I take so many people directly from the hospital or detoxes who are usually on a moderate, if not therapeutic dose. But definitely I think it's the same, I guess, answer that I would have about the balance of, in-person assessments and rapid titration, which is, if a patient is struggling to stay awake during our encounter, I will acknowledge that and acknowledge that that's impacting my dosing decision today. But that, I welcome them to come back tomorrow and like represent and be reassessed and, potentially have their dose more aggressively titrated when they are more alert. But I think, we have to use the clinical information that we're presented with, and we can't kind of unsee if someone's eyes are closed. So I just am very open and transparent with the patient about like, if I'm like, okay, I'm only going to start you on 20 because you're looking kind of sleepy, and they say that's not enough. I said, okay, I agree that's a subtherapeutic dose. I would love to start you on a higher dose. However, you're presenting very impaired. So, maybe we can take you up to 40 tomorrow if you come in appropriate, so we trying to make a plan. So, but I'm sure there'll be other answers in the room that are great. But yeah.
Hi, Rob Sigadel, Neponset Health Center. Thanks for the excellent presentation. I have two quick related questions. One is how the use of benzodiazepine affects your deliberation. And the other one is that patients who drive back and forth to the clinic, how does that affect your thinking on rapid use of methadone?
Those are great. Concomitant benzo use is highly prevalent among my patient population. And I think it again is about, is this person using benzodiazepines in a risky or dangerous way to the point that they're impaired in front of me? Or are they kind of, medically managing their own symptoms in a dosing regimen that would be prescribed potentially, but isn't? So I think taking that into account, and then similarly having an open and honest conversation with patients about that, like how that's impact. Like I would go faster with you if I wasn't so concerned about your benzo use. Just put that up there. Say so I just try to be transparent about what's informing my decisions, so that me and the patient can have a conversation about it. A lot of the patients I take care of also don't drive. But I definitely think that is important to counsel patients about, whether it's a rapid titration or a dosing error, right? I think that's important to, if you have a concern, I definitely think expressing that and having them be more aware about the risk of sedation at the peak, whether they're driving, whether they're operating heavy machinery at their job, climbing up a ladder at their job. So, getting to know them as a person and their individual risk. And I think that's a great thing to have as part of the counseling conversation. Oh, sorry, that's my pager. Is to know, teach patients about when you expect a peak and discuss any, activities that they do that might be dangerous.
Well, quick follow-up. That may well be true, but a lot of people, I worked methadone before. And I know that every year we had people who left the clinic and crashed their car, maybe within the next couple of hours after dosing. And again, there is third-party liability if somebody runs over somebody in a baby carriage. I don't think it could just be a joint decision with the patient. The patients don't always use the best judgment in terms of things like driving.
I guess we're presenting people with options. Everyone has their own risk tolerance as a prescriber and provider, right? We're not telling you you must do something that you're uncomfortable doing. You have your own medical judgment and your knowledge of the patient. And so no, I don't think I think this is more to empower people to be more wide thinking about what their judgment could be, but not to substitute it. And I think it's important to think about that and have a healthy respect for this medication that can be dangerous, the same as many other medications that we prescribe, right? We could prescribe too much insulin and someone could also have a loss of consciousness event, right? So
Thank you.
Alan Wartenberg, formerly from Faulkner Hospital and now retired. Have you given a thought to measuring peak and trough levels to determine what the half-life of methadone might be so that you can identify those couple 3% of very slow metabolizers? Would that be useful?
I mean, I'll speak on the inpatient side and say that I think we won't do it there because it won't come back enough to really affect our clinical decision making. So we're really just going to go by what a person looks like at the time of their peak effect from the individual methadone doses, but I'm not sure in the patient setting.
oh yeah, we will get that lab a week later. So
Yeah.
But I think that's another really important point about something unique about this medication relative to some others is that there really is that individual metabolism. And like I said earlier, if a patient is methadone naive, they've never taken methadone before, they could be a very slow metabolizer and you just don't know. So I think that's a very reasonable reason to have more caution if you don't know that, right? And if you're treating, thousands of patients, some of them are going to be slow metabolizers statistically. So.
Thanks for the wonderful talks, Miriam Kumarami from the Reagan Center at Boston Medical Center. Zoe, this is something you and I have talked about before, and I realize I'm still a little murky on it. When I see patients in Faster Paths, our bridge clinic at Boston Medical Center, they're often caught in this conundrum in which they want to get started on methadone, but they also are trying to get into a rehab program. And they're told, oh, you can't do both. You can start on methadone, but if you do that, you won't be able to be continued on methadone when you go to a program because your home clinic can't set you up for guest dosing and for 6 weeks. Is that Massachusetts? Is that federal? Is it individual? Like, where does that come from and why is there that rule?
It's a good question for BSAS.
I think and this is recorded, so we'll see, but I think 7 years ago, 8 years ago, there was no such thing as like a direct admission. People weren't being started in hospitals or detoxes and connected. So that was like a new phenomenon. And like all things, we need to learn a language to describe a new phenomenon. And so the conception of that model was that these patients in the methadone system were what we would call like a guest doser or host doser. And so that's because they did not belong to really anyone. You can't be a guest of a guest. So you have to have a home. And so in the, I think, original conception of these direct admissions, they're kind of seen as these wait list, interim, or host guest dosers. and they need a home clinic and to have completed a full intake in that home clinic to do guest dose paperwork. I think that understanding has evolved, and BSAS is welcome to correct me, where I think our DPH colleagues see those patients as belonging to us, and that technically we could do that paperwork. I think, however, given the many competing demands and understaffed and infrastructure of the OTPs, that cruise ship has not turned yet, where that's like really being fully embraced. And it obviously has some downsides too, which is if a patient is always kind of at a program and you've never actually met them, but you're responsible for their dose and you're responsible for their dose adjustments, it is very challenging to do that if you've ever actually met them. So I think there are some real reasons why that doesn't happen. And I think some of it is historical holdover of how we've conceived of those patients. And then I do think we just need some more focused attention to that issue. And I think it is overcomeable with focused attention. But I welcome corrections from
I'd love
BSAS.
to see it overcome. It seems like it's the opposite of patient-centered care. Yeah, so, thank you.
This is Jen from BSAS. Hi, everybody. So Zoe, you said it perfectly. It is historical kind of holdover, and definitely our progress of treatment hasn't caught up with the communication to all continuum and levels of care. It's a good problem, but here it is in our face. So now we have to work on that, and it's definitely something that we are going to be working on with everyone. We could have full workshops on that, which is complicated. And it's a lot about just collaboration and, talking ATS to OTP physicians and trusting each other and building those relationships. So the regulations allow you to do that, just so everybody knows. Thanks.
Hi, I'm Natalie Stahl from Greater Lawrence Family Health Center. We talked a lot about how OTP directors have medical directors have a lot of autonomy, and systems really differ. So I think I don't work in OTP, but I work in the hospital in the outpatient setting. So for the inpatient side, do you ever get pushback from OTPs you're doing direct admission to about your dosing protocols? And if so, how do you reassure them? Is there anything you do to reassure them? And then for Zoe, for the outpatient side, if I'm an outpatient like doc on the mobile health unit, and I think a patient's maybe not being escalated in a way that might be helpful, that I know is hypothetically possible, do you have any recommendations on how I might communicate with a medical director?
Well, I think part of my hope in doing this presentation today was to have more talks with OTP directors who are concerned about our approach and really have a chance to explain it fully. In the past, when we have gotten pushback, I think a lot of what I focus on is, what we've seen with the patient, that we've seen, and I really think it's important to see the patients like 4 hours after their methadone dose if you're rapidly inducing them, because then you can say, like, I've seen them at the peak sedating effect. And I don't think it's unreasonable to want to see someone at 3 days of dosing, like that's sort of that 87.5% of the steady state. I do try and push back on when we're asked to hold someone at a dose for longer than that in order to discharge them. My hope is that publishing also the data that's now in Substance Abuse Journal will also help make this a little bit of an easier transition.
Yeah, and I guess on the reciprocal end, no, I think more communication is better. And many people in this room have my cell phone and text me about things.
Same.
And that's not the optimal communication, but it's sometimes necessary. And so I do think it's really sometimes helpful to understand what's happening from the OTP side and from the outpatient side, because we're only seeing patients for that brief period, and to really better understand what are the barriers, what are some of the solutions. I have providers call me and say, hey, I'm about to start this patient on rifampin. Like they need more methadone. Like that's really helpful to me. There's no way as the OTP director I'm going to know that. And it's very challenging to expect a patient to communicate that. So I say, like, get an ROI and please call me and tell me whatever you think I need to know.
These are great conversations. I hope they continue, and I'm sorry to do this, but to keep us on time, we are going to break. We are coming back to panels, so you will have more time to ask Evan and Zoe questions and the panelist questions. I want to thank both of them for their expertise.